Hi, everyone. Welcome to our new podcast. Today, we are speaking on allergic rhinitis and asthma related conditions. We have with us today Dr. Liu Jiaying, ENT surgeon, as well as Dr. Alvin Ng, who is a respiratory physician and intensivist.
Hi everyone, I'm Dr. Liu Jiaying. I'm a ear, nose, throat consultant and surgeon. I practice at Orion ENT and Hearing Center. I see all ear, nose, and throat conditions as well as snoring. I see adult and children as patients, and you're welcome to reach out to me if you have any ENT queries.
Hello, everyone. My name is Dr. Alvin Ng from the respiratory practice. I'm a respiratory physician and intensivist. You can find me at level 1208 of Farrer Park Hospital. They run regular clinic sessions there. Patients I see anything that concerning the lung in the outpatient setting, and so asthma, as well as COPD, coughing, pneumonias, diagnosis of lung cancer, pleural effusion. So the list is numerous. And I also, as I'm also an intensivist, and intensive care medicine is a bit like the GP of the very sick. So I'm a specialist not only in the lung field, which is the organ, but also a specialist on site of care. So when patients who enter the ICU, I look after them. They're very sick. They can be on dialysis. They on a life support machine. So I see the sickest of all the condition, and so I always feel that I'm like the GP of the very sick. I look after all the organ systems, and but of course, if we need help from other specialists, we will call the specialists to come in and help us. But we need to manage the patient overall. So that's what intensive care medicine is.
Thank you for joining us, doctors.
Yeah,
Thank you.
thanks for having us today.
So, we'll just deep dive. What is allergic rhinitis?
I'll take the question. So, rhinitis is a form of inflammation of the nasal lining or nasal mucosa, of which allergic rhinitis means the patient who has it has an allergy, most commonly to allergens in the environment. And it is actually very prevalent in Singapore. The prevalence of allergic rhinitis in the total Singapore population is about 24%, of which the preponderance is in the younger population under the age of 30. And school-going children actually have a prevalence of about 44 to 48%. So it's actually really common in the younger population of Singapore. The more common aero allergens in Singapore would be to house dust mites, as well as to pet dander, so like cat hair and dog hair, as well as to pests like cockroaches. This is quite unlike in the European populations where pollen, also known as hay fever, allergies are more common. In Singapore, it's mostly house dust mites, pet dander, as well as cockroaches.
So, can allergies develop at any age?
Oh, yes, certainly. Allergies can develop at any age. And it's also kind of related to the exposure the person has. If you have repeated exposure, with each repeated exposure, the ability of the body to actually react excessively is even more. So that's why allergies are also known as a hypersensitivity reaction, where the body overreacts to a certain stimulus which is otherwise quite benign.
So, what are some signs and symptoms of allergic rhinitis that you see in your patients?
Sure. This is a good one because I think most people can tick off the list of what they feel. Most commonly, if you have two or more of the following things like blocked nose, running nose, itchy nose, sneezing, and some people even get itchy eyes and watery eyes or red eyes, then I think you need to consider that you might have allergic rhinitis. The duration of how long it lasts is also important. So if you have it for like more than an hour, almost daily, then that is something to consider as well.
So, Dr. Alvin, maybe you could share with us in the patients that you see, is there any direct link between allergic rhinitis and asthma? Can you have both of these conditions at the same time?
Yeah, also actually asthma and allergic rhinitis occur commonly together. That's also together with eczema, so it's like a triad of atopy. Sometimes you may have all three, sometimes you may only have one, sometimes you have two, sometimes you need to control other factors to get your cough down. Now, what we do see is commonly is a presentation of chronic cough. They keep coughing and coughing and coughing, and sometimes you just treat the nose alone is not enough. You need to treat the lungs, and sometimes you treat the lungs is not enough. You need to treat the nose. As to chronic cough, asthma is one of the common presentations. So earlier your comment about is age a factor? I actually see quite often in asthma patients, So if I diagnose asthma in an older age group, patients often tell me, hey, come on, your asthma is for kids, right? I'm of this certain age group. Why are you diagnosing me to have asthma? Now, often than not, I'll tell them that the classic asthma that you think about, like they happen in kids, those are probably more severe, so they present earlier, right? So it's the quiet ones that takes a while to show itself as the lung condition deteriorates with each trigger. So only after a certain age, right, they come, and then we test them and we listen to their lungs. You don't hear a wheeze, so they often get missed. So I need to use like tools to diagnose it, like a lung function test. And then then comes the question, right? How come I don't have a wheeze? How come I don't feel breathless? How come I don't react like what I see on people who have asthma on TV? And that's when I tell them they are mild. It's not hard to, it's difficult to pick it up. So I need to use the lung function test in order to tease it out. But the best way to prove it is to treat the asthma. So how we treat asthma is that we use inhalers that have the medicine go directly to the lungs. If they have allergies, then we have to ask them to avoid the allergies. They got allergic rhinitis, treat the allergic rhinitis as the triggers. And that's how I see a lot of patients with chronic cough, and this is often what I tell them.
So just a quick question here, since we're talking about these two conditions, does having one predispose you to the other? Is there any link in that sense?
So it's a one airway condition. So a lot of us believe that the nose is connected to the lungs, and you need to treat. Sometimes you need to treat both to get your cough under control. Sometimes there's one that's more predominant than the other. So it really depends which is the predominant. So even if let's say your cough goes away by treating your allergic rhinitis, that doesn't mean that you don't have an asthma. And other triggers can come, because allergic rhinitis is not the only trigger for asthma. Like infection. So like COVID, right? COVID, a lot of people say that, oh, you can have this long COVID. And actually a lot of people, after hearing this thing about long COVID, right, they think that, oh, I'm coughing very long, so this is long COVID. But actually, we really know for a fact that viral infections trigger off asthma. And then it is one of the things that cause you to have to trigger off asthma. So my suggestion is that if you do have a lot of coughing that lasts longer than others after infection, then do see a doctor. And if it doesn't get better, consider see a lung specialist. We can run a lung function test for you, and then try and tease out this diagnosis of chronic cough secondary to asthma.
Yeah, certainly. So, Alvin just mentioned that actually it's a unified airway where the nose is actually connected in some way to the lungs. And yes, allergic rhinitis can cause problems such as excessive mucus production, which would then drip from the back of the nose all the way down and irritate the larynx, and then which then will trigger irritation of the lungs. So that's how allergic rhinitis can also exacerbate asthma. And so they are kind of connected in some way.
Lingering cough is a symptom of allergic rhinitis. Dr. Alvin, you shared about the cough. So I
Yeah.
think that kind of covers
Well,
it
I mean,
already.
there are many different causes of coughing. So it's not just allergic rhinitis. It's not just asthma. You could have even certain drugs that you take, like even some type of antihypertensive medicine that you take can even cause cough. It can also be from a lot of us believe like reflux, like gastroesophageal reflux, where the gastric acid comes out and burn your throat. And often than not, the ENT side, like Dr. Jiaying will see that there's some burns along, perhaps some swelling or burns around the larynx when you do a nasal endoscopy, right? To see that. So there are many different causes of coughing. But the common ones, allergic rhinitis, asthma, and reflux. I think these three pretty common from the patients we see, right?
Agree.
So do you actually refer patients to each other because there's an interlink?
Sure, there is. But maybe something which we should definitely make our listeners remember is that someone with a lingering cough which doesn't go away, plus risk factors like smoking or family history of malignancy or previous cancers, should definitely get it checked out earlier rather than later. Yeah, because we're worried about something more sinister. Would you agree?
I agree that a lot of my patients come and see me. They will tell me, doctor, is this cancer, right? So I will often tell them that I will do an x-ray first. And usually if you're coughing so badly, right, the cancer will be obvious on an x-ray. So I might see something, then it goes to a certain track. But the main issue about cancer is this. I tell them that negative x-ray doesn't mean you don't have a small cancer or something that's hiding behind somewhere. And the problem is that if you really want to make sure there's really no hint of cancer, then I would suggest a low-dose CT lung screen to clear the lungs structurally. So I always look at structure first, then function. One more note about lung cancer is this. A lot of times, without doing a CT lung screen, without a CT scan, you cannot pick up the cancer early. So let's say for an allergy, right, we open up the lungs and we put on a football field. And let's say cancer is a football, right? This football, anywhere in the field, right, will not give you a score because the lung is so big, right? Unless for some reason you manage to do a scan and the goalkeeper catch this ball, then you manage to save it. If not, right, there's no feeling anything in the lungs, and you might have to flood half the field or quarter of the field. Then you start to feel breathless. When you flood half the field means what? Means the cancer has already spread to the lining of the lung, and already water accumulates outside, and that's when you feel breathless. And by then it's considered metastatic and the late stage. So often than not, lung cancer, no symptoms. Often than not. So not that but of course people when they keep coughing, they worry about lung cancer. Sure, we can do a scan to try and make sure it's not that. But often than not, lung cancer, no symptoms. Early stage.
When you mention chronic coughing or long-term coughing, what kind of time frame are we looking at? Something that if you're coughing beyond X number of months, then get it checked out? How little and how much before you actually do like an in-depth check, like, hey, I'm coughing for too long?
Classic teaching when I was a medical student is 3 months. But after that, I see patients coming to me after coughing for 3 months, they're really suffering. So actually, I do start investigating earlier. At least make sure it's not a pneumonia or something like that. So if your cough is really not going away and bothering you, see a doctor early, and then we can take care of the early causes of coughing and the chronic coughing causes too. So to come by and if you're concerned.
Is allergic rhinitis something that goes away, or is something that you live with?
Okay, so allergies are something which don't completely go away, but they can be managed. And it really depends on how severe the patient is suffering first. So we have a baseline check of how severe the symptoms are, and how we usually classify it is about how often the symptoms are and how severe do they affect the quality of life, like sleep, do they miss school, that kind of thing. And then from there, then we suggest treatment according to the severity. Of course, there are patients who actually come with complications of allergic rhinitis when they first see me. So certain things like sinusitis, that means sinus infections, where the mucus stays stuck there, and then the bacteria comes in, and then you get sinus infection. And also, you'd be surprised, but actually the allergic rhinitis is linked to ear problems. So if people who chronically have blocked nose and they have a lot of sniffing, they tend to have eustachian tube problems. And in younger children, they may have persistent middle ear infections. So allergic rhinitis definitely needs to be controlled in those conditions. Also, it can also give patients very bad quality of sleep through snoring or obstruction of their breathing passage. So there are different ways allergic rhinitis can present also, not only the classic ones, but it can be managed. And I think we first have to maybe take a step back to find out what exactly they're allergic to. That's very important because the tenets of managing your allergic rhinitis is understanding what is triggering you in the first place. So patient education very important, and we need to tell them what to avoid because everyone's body is different. So you need to have a treatment catered to what you are allergic to. Then after that, once you know what you're allergic to, you have to avoid it. And that also is a different set of counseling based on what you're allergic to. Then the next line is medication. And if medication fails, there are newer things nowadays like immunotherapy.
So if you go back to the fundamentals of allergies, now we all know like, oh, you go for a prick test. So apart from external factors, do you see cases where it is actually triggered by something that you eat?
So allergies can be something floating in the environment, that means environment, or it can be food. It can be also things like medications that they have been eating. So there's drug allergy. Yeah, so based on the story the patient tells you, then you can actually direct your allergy testing according to what they have. Yeah, but if they don't have a specific thing which they're allergic to, then we usually do maybe a screen of both a bit of aero allergens as well as some food testing to see what they're allergic to. And there are a few ways to do it. So obviously the most common would be a skin prick test, which is the fast and quite fairly reliable way. But some people are not good candidates for skin prick testing say they're very bad eczema, and anything can trigger their eczematous condition to worsen, or they have history of anaphylaxis, which basically is a super severe reaction where it's life-threatening. So then we avoid those, and instead we do a blood test for them.
I'm not sure whether you experience this, but my patients, right, once they get better, once the cough get better, they stop taking the inhalers. So I see it quite often. Because asthma is like a vaccine, I presume allergic rhinitis is probably the same, but I think allergic rhinitis maybe a bit more. They can feel it dripping. They know how to soothe. But sometimes some of the asthma patients, they even as the lung function declines, they may not know. I often picked up patients who are like in the older age group, right? As you'd be surprised, sometimes they present to me, right? Their lung function is about 35% of the expected at presentation, which means that he have slowly declined. They may credit it to aging, not so fit anymore. So they thought that they're just not so fit. But actually, it's actually the asthma triggering. If I treated them earlier, right, maybe they can be our next Olympic star, So so that's one group. Then the other group is patients who once they get better, they feel that they're cured and then they stop taking. Then you'll come back. And so we do see that. It's quite common. I think the idea is about educating the general public, precisely what we're doing, to tell them that, look, chronic cough, consider asthma, consider allergic rhinitis. If you're better, you may have to listen to your doctor in terms of how to slowly tail off the medicine. Or sometimes you might even have to take lifelong medicine, at least for asthma, some cases. But some cases, I can still take it off and use it as and when needed. Some people think that it's like like I label them as asthma. Sometimes I get a reaction like it's like a death sentence with some. Some will feel like, hey, how come I got this diagnosis? But often than not, I tell them, that whether I diagnose it or I don't diagnose it, if you really have it, you really have it. But if I can teach you how to better manage it, then at least you know how to better deal with it. It doesn't change the fact you have it, right? Whether I diagnose it correctly or not. If you have it, you have it. But if I'm really correct, then I will be able to teach you how to better manage it.
So end of the day, it's down to management, right? The better you manage it, the better you can keep it at bay lah.
Correct. And also sometimes you may, like I said, the asthma is undiagnosed, right? So that day I got one patient, example, came into the hospital, fever, cough, breathlessness, and there was an X-ray showing a pneumonia, right? But the patch wasn't very big. Blood test wise, also the infection markers isn't that severe, but she was so breathless. So I brought her down to the ICU, standing by whether I need to put a tube down or life support to put on life support. She's so breathless, right? But I decided to give her asthma treatment because I thought it was out proportion. It's maybe another process happening. And when I listen to the lungs, right, again, I don't hear a wheeze. And she's maybe about 40, 50 years old. So I treated her for asthma with pneumonia. Like the pneumonia itself is a trigger. It's an infection, trigger off asthma response. So I treated her for both, presumptively. And then when she got better, she came back and see me in clinic. I do the x-ray, the pneumonia clears up. And then only then I did a lung function test. And lo and behold, she has asthma, undiagnosed.
A lot of times you pick something up from something else. That happens all the time in your practice. It's accidental findings.
No, I don't think. Well, sometimes of course, sometimes it's accidental. Sometimes patients are very clever. No, doctor, I have this. Then you have to believe them. You test them. And sometimes they're correct. Once one patient say, oh, I the way I cough at night, right, sounds exactly like this, like a whooping cough. And true enough, it was whooping cough, It's very sharp. So, but I think a lot of times it gears down to experience. The more you see, the more you know. Well, in the textbook, we learn what in textbook a lot of times is the standard one. Like the standard young kid with the asthma puffing away. But there are all these variation. The mild ones are the ones that are difficult to tease out. So I think that's where experience counts. The more you see, the more you experience, the more you know that you can present it this way.
So back to these two conditions. With this link between the two, can they actually be treated by a single medication?
Well, there's a medicine that was used to be, not used to be used, but it's still being used, like montelukast, anti-leukotriene inhibitor. Supposed to target both the upper respiratory tract, like the nasal mucosa, as well as asthma. But I think for asthma, the pillar of treatment is still an inhaler. It still works best. The montelukast do work in a subgroup of patients, but there are some concerns with that, the medicine also. So I use it carefully. But I'm not sure in your practice do you use it.
So yeah, I would say that the leukotriene receptor and agonists are the medications which probably traverse to specialties, but it's not the backbone of the treatment. So we still, for the allergic rhinitis, our backbone of treatment is the intranasal steroid sprays, and then we add on extra things like antihistamines, be it oral or nasal. And then if the cases don't work and the patients are asthmatics as well, then we will consider the Montelukast, which is what he has said. But use carefully because there are side effects, which nobody likes those side effects. So we use them very carefully. But actually, for what Alvin said about patients who are not compliant with treatment, actually I do agree. A lot of the patients, when they get better, then their compliance dips, and or rather they stop. They medicate and they know themselves best and they stop the medications. But I feel that the ones who don't do well, self-selecting will come back. And that's when I have to offer high-level treatment, and some of them may need surgeries to relieve nasal obstruction. There are also some kinds of devices to help running nose conditions. So, but for the ear cases, definitely it's a bit of a longer recovery period because ears take a bit longer to treat, even with allergic rhinitis treatment on board. Yeah, so I do agree with him to a certain extent. Yeah.
So for ear cases, do you see it present more in the generally older population, or it's
Mm,
across the board?
it's across the board, but usually the younger patients, anatomically, their eustachian tube is at an angle which is more horizontal, so it predisposes them to reflux of the nasal secretions, and also it's basically just an immature eustachian tube. So the younger age group tends to get eustachian tube problems, but there are also adults who get it, and it can be triggered by a very bad bout of viral infection, and then say they are traveling, and then they take an aeroplane up and descend. Ascend and descend of the aeroplane flight triggers conditions to be worse. So that happens as well.
So before we end, we just like to ask our two specialists here, what is that one tip or advice that you want your patients to remember when they have these conditions?
If you're coughing or you got symptoms like breathless, I mean, at least for asthma, right? Coughing, chest discomfort, a lot of phlegm, get it checked out. I think the first thing, get it checked out. First, you must be able to diagnose it. Once you diagnose it, it's about managing the triggers, like allergic exposures, or try to get your vaccination done to prevent infections. Must start in high risk areas if you need to, and then balance it against the scale. So asthma is a bit like a weighing scale, right? The more triggers you get, you need to balance it with inhalers. So some patients, without much trigger, they don't have much symptoms, so you don't need so much medicine. So some patients react very badly, so you need very high doses. But the idea is that once we give you the medicine and you improve to a certain level, then we slowly cut back. But a lot of times, once they feel better, right, they cut back too fast and it tumbles quite badly. So I think the idea is get the condition diagnosed and then manage it appropriately. I think those are important.
I would say know what you're allergic to. That's very important. For all allergies, be it allergic rhinitis, so avoidance is number one, and look at it as a long term, because it's not going to be, a lot of patients come and they want a quick fix and they just take one course of medication and be done with it. But it's a waxing and waning course of ups and downs for allergic rhinitis. So they need to understand that there'll be periods of time when it will worsen, then they have to restart their medication if they've been tailed off also. Yeah. There is some hereditary component. So if your family members, be it parents or your own children, have some form of allergic rhinitis, also be more cognizant that you might be more susceptible to it as well. So everyone should in the household should also have some allergy avoidance plan as well. Yeah.
So thank you very much for joining us today, Dr. Jiaying and Dr. Alvin, for this very insightful sharing. We hope that you guys listening in have a lot of key takeaways and things to consider. And if you do experience any of these symptoms, please speak to our specialist today at Farrer Park Hospital, and we'll see you at our next podcast soon.
Okay.
Thank you for having
Thank you very
us.
much for having us.